I've been a transplant surgeon for about 40 years. I was professor of the clinic here in Helsinki, and I was also head chairman of the European Transplantation Association some years ago, and lately chair of the Scandiatransplant organization until 1 month ago. Right, let's see now. I cannot start a talk without giving the name of this man. Many of you have seen him, you have heard him a lot. I used to play tennis with him still.
So you're a very good tennis player?
Oh, well, yeah, well, you should not beat him, you know, so you have to adjust. One learns something in life. No, he's an excellent guy, and he's close to 90 now, and always we'll meet in Wimbledon outside the court and at the matches. Taffy, Maurice Slebak, who started World Olympic Games for transplant patients, actually. A few words about this transplant center in Finland. There's only one, and that's Helsinki, where I've been working. And there's the abdominal center, which is the larger one, where we do the kidney, liver, pancreas, intestine, and we also harvest all these organs, also for children. Then we have the heart and lung center, and you will hear Ari Harjula talking about that soon, later. And then we have the children's hospital. The transplantation surgery is very specialized activity, as you have seen, and one transplantation, actually, people tend to forget that, involves at least 2, very often 3 operations. The first is that the donor organ has to be harvested, usually many organs at the same time, usually at a different city. Then you have the recipient, and in some patients you remove the sick organ, which is for the liver patients, heart, lung and intestinal patients. And you don't have to do that for the kidney and pancreas patients. And then the new organ is transplanted in place. And the organ donation procedure, when you go by plane somewhere, takes usually 6, 7, 8 hours. And then you start the transplantations, which take between 2 and 12 hours, the operations. It depends. This is just to show that without organs, donor organs, we don't have any transplantations. So one of our main tasks is all the time talk about organ donation and the importance of it, and how patients listed for transplantation die on the waiting list before they get a new organ. And here are the 20 hospitals listed here in Finland. The blue, these are 20 hospitals. The blue ones are University Hospital, and in top you can see from eastern Finland, the home of this guy here. I'm not showing it only because of that, but because they have been in the top of organ donation rate for years. Really, they are doing very well. And then we have the rest of the University Hospital, and then we have the normal hospitals for districts from the rest of the country. About the medical treatment, surgery is of course the foundation of everything, but there's no success without immunosuppression therapy for the patients, really. So why? We should remember that if we don't use some kind of immunosuppression, the patient dies sooner or later, not in 1 day, not in 1 week, perhaps not in months, but it depends on when they stop. The difficult thing is how much should we give them. Too much gives side effects, too little gives rejection. So here we have the options. Should be, of course, the optimal side. Too little gives rejection, and too high doses gives problems, severe infections, sepsis, malignancy, and other side effects. So one has to take it that they need lifelong immunosuppression. We all know that there are exceptions, very few ones, but there are more patients who have stopped treatment, who have died, and these are not written about too much. Only those who survive without immunosuppression for some time are noted perhaps. But also another thing which is unfortunate perhaps, the main medicines, which is cyclosporin and tacrolimus, they have been here for 40 respectively 20 years already. They are strong enough, but they have too many side effects. But the patient can't do without one of them. That's the problem. They get about 1/3 of them get rejections, which usually can be diagnosed effectively and treated promptly. And chronic rejection is sometimes a problem, but much, much, much less than, let's say, 20 years ago. Here's just a list of these different kinds of medicine which are used. My advice to you is that you don't have to know these by heart. You just should remember that if there is something wrong with the patient you have in front of you, the transplanted person, then you should call to the transplant center and ask, could this be a side effect, vomiting or whatever, fatigue or whatever. Phone them. They are happy if you phone them. Here you have the when these drugs came to the market, and the important thing is perhaps that all these different drugs have been studied very, very carefully. All the different drugs have a special point of activity in the progress of T cells. Everything depends upon the T cells. The bad thing with cyclosporin and tacrolimus is really that it reduces kidney function for all patients, more or less. And this is the best study so far. This is 15 years old already, but showing when the patients are 10 years out after transplantation, how their kidney function is reduced. We can see here that it doesn't not affect too much the heart-lung patient or heart patient, but in particular liver and intestinal transplanted patients, the kidney function is reduced. This is my main slide actually, and if you don't remember anything else, I don't used to remember too much when I'm on listening to speakers, even from my own area, without checking again. But this is the main slide. Here are 7 different problems listed for the different 5 or 6 drugs which are used, and all of these can be most terrible. Even the neuro damage, they get some wasting. It doesn't matter too much if it's twisting, but they can lose sensation and they can walk like this, like an old man, almost my age. So all kinds of problems they can get. Hypertension is very useful, hyperlipidemia also, and hyperglycemia, and even diabetes can follow. But this is of course not your problem. You should be aware of that and fix your eye on some lab values, and if something is wrong, call them up. In Finland, from the liver transplantation area, which is my area actually, I did the first one in 1982, which was the first in the Nordic countries, also happened to be. Our patients really, you can see here, when they are 10 years out, 8 of them have very severe kidney damage. Glomerular filtration rate is very low, close to dialysis, and almost half of them have at least slightly reduced kidney function. So what do? You stop the cyclosporine or tacrolimus and you can reduce it and increase to another mofetil drug, for instance. It would be easy, but it's not possible for all. Some get severe rejections. And then we have new drugs here, listed down there, everolimus, sirolimus, but they are not effective enough in the long run. And in the beginning you cannot only rely on them. So we are a little bit in the trouble. Here's just a slide showing a patient out there who has had a sirolimus, rapamune, cyclosporine, and increased creatinine. Then you take away cyclosporine, continue rapamune, and the creatinine goes down. So, after transplantation, which is in where you see them often, I hope you see them before also, I hope you see them when they are listed, they have immunosuppression. They want to ask you, why can't we stop? We have exercise now here and Olympic Games and so on. Be careful. Tell your doctor that here's a suspect. Patient you have regular post-transplant control. Fortunately, the risk of infection are increased by time. Unfortunately, risk of malignancy increases by time, usually skin cancer, but also a lot of other cancers. This is the patient survival for kidney transplantations. 10-year survival, patient survival about 80%. The same is for the liver. I just want to show about quality of life. My last slides here about my favorite patients, of course, which are the liver patients. This is one of our studies which has shown that the quality of life in 12 different issues, it doesn't matter if you can't read them, there are 12 different normal issues. And the dotted line here is the normal population, the solid line is the patients. Just in a few issues they are inferior to the normal population, but in most issues they have the same. That's sleeping and eating and walking and so on. Here's the working capacity of the liver transplantation afterwards, and one can see that dependent on the age, of course, they have a greater capacity to work, but even over 50-year-old patients, 1/3 of them almost, do their work, usually a new work actually, which they didn't have before transplantation. So my conclusion is, please remember that the patients are transplanted for a life-threatening disease, and it takes some time because they can get over it after transplantation. Suddenly this disease may cause serious damage also to other organs, and in that case sometimes if they go kaputt, as they say in Germany, yes, no, then you can do a 2 or 3 organ transplantation simultaneously. Remember the pre-transplant, just normal diseases, hypertension, all kinds of infection, diabetes, fragility, and check the functions of the main 5 organs we have, which decides will we live or not. These are the 5 organs: heart, lung, kidney, liver and brain. Comorbidity is treated with ordinary specific drugs, as for any patients, and certainly physical activity is helpful, and even sports possible, but should be individually tailored. I myself have done sports, I was about to say since I was born, and I'm still doing all kinds of sports, running and tennis. Thank you. I'm ready to answer some questions.